Hello, people will be joining, but we'll start now. So welcome to this session. My name's Penny. I'm the Managing Director of Q at the Health Foundation. For those of you who don't know, Q is a community of thousands of people across the UK and Ireland who are collaborating to improve health and care. Q is delivered by the Health Foundation with co-funding from NHS England and our partners across the UK and Ireland. We're really excited to be working in partnership with NHS providers on this programme. These peer learning events and resources, they're designed to help board members explore all of the challenges, the opportunities that you face in creating a positive improvement culture in partnership. And that really includes, as central, how to embed a focus on inequalities into existing and new improvement work. Now, I guess what we're hearing from you, what we understand is that this is emerging early stage work for most people. So, these sessions, they're a peer-to-peer space to share where we are on this journey. So it's just a chance to take learning from improvement work at trust level, consider how that might apply when we're looking across provider collaboratives, and we're making links to some of the improvement expertise of the Q community and the Health Foundation as we go. We've got a really great programme with some kind of practical examples of work taking place, combining that with a little bit of space to reflect, consider about how what you're hearing could be applied into your own work. And what a panel we've got. So we're going to start with Kate Cheema, who's the Director of Evaluation and Insights at UCL Partners. She's been a long-standing Q member. And then we also have, hopefully, Mark Liddington is going to join us, who's the Medical Director for Planned Care at Leeds Teaching Hospitals and the Medical Lead for Elective Recovery at WYAAT. He's having a few technical problems joining us, but hopefully will be with us shortly. And Jack Dunne, who is the Programme Analyst for Planned Care at West Yorkshire ICB. Just going to do a little bit of housekeeping before we get going. It's here on the slides, so I'm not going to go through everything. If we could have the housekeeping slides. If you have any logistical questions or problems, please just add those in the chat. If you can keep your cameras on throughout, that would be great, but please mute your microphone when you're not participating. I'm hoping that we'll see kind of active use of the chat for those of you who find it useful. I know some people find it a bit distracting, so just hide it if that's you. If you haven't done so already, it would be great if you could just introduce yourself and perhaps share something that you're hoping to get out of today's session. There'll be time for questions and comments throughout, and we've got some dedicated time at the end. So please post questions in the chat. I'm going to keep an eye on that and make sure we bring them into the conversation. Or you can raise your hand, either using your the kind of hand function on the computer, or you can actually just wave and I'll make sure I bring you in. This meeting is being recorded for anyone who missed the notification. That's so that we can share the presentations from this session on our website and promote that to members. But we won't be sharing anything from the breakout sessions. I'm hoping that's all clear. Why don't we move straight on to our first speaker? Again, really excited. This is somebody who we calculated we've known for at least 10 years. I'm going to let Kate introduce herself. Over to you, Kate.
Thanks very much, Penny. Delighted to be here. Thanks for having me. I understand that Danny is in charge of the slides, so I'm going to channel my inner Chris Whitty and ask for my next slide, please. And actually went on from that, when Penny said, "Are you okay to introduce yourself?" I nodded and went, yeah, sure, that was great. And then remembered that actually I've got an entire slide introducing myself. So if I could have the next one, please, Danny. So a super quick introduction to me. There's a potted career history on the slide there, and one of your takeaways might be that I've spent an awful lot of time in CVD in the past 4 years. And there's a nice pic of me there teaching patient safety leads about funnel plots some time ago. I'm not sure I fit into that dress anymore. That journey is underpinned by backgrounds in research methods and statistics, and my kind of primary interest really, and kind of the focus of what I'm reflecting on today, is that interface between data and intelligence and action, and this concept of a semi-permeable membrane that seems to exist between evidence and decision making. That means it can take a lot of time for evidence to actually make a difference. I'll touch briefly on the importance of analytics career pathways, and if I have time, get my soapbox out to talk about it as well. But hopefully Penny will call me to a halt before I get too into that. Can I have my next slide, please, Danny? This is one of my favourite quotes of recent years. She came from the chief executive of the NHS, and if you'd listened very carefully, you would have heard an uproarious cheer from all of my analytical colleagues across the NHS, because we've kind of been saying this for a while. And whilst we kind of wholeheartedly approve of the sentiment, it does mean that it follows that bad analysis can potentially harm more people than a bad anaesthetist. Let me just kind of dive into just for a couple of minutes, if you'd indulge me, in terms of how does that actually track. And so I wanted to give you an example from which I've slightly anonymized from once upon a time in an analytical job that I held many moons ago, which is kind of a transformation question, which was basically about where we're going to site not quite a whole new stroke unit, but particular specialist services around stroke to meet the most patients who would benefit. So save the most lives, reduce the most morbidity, and let's be honest, save some money as well. And some of the elements that we considered were things like relative distance to other hubs, accessibility for the right staff, the communities it was meant to serve, to some extent at that point in time, the inequalities that it needed to address. So who were the most needy populations, the volume of people likely to come through, how that translated to things like blue light response times, etc., etc. Every single decision that was involved in answering some of those questions was underpinned by analysis and interpretation of data, and not just quantitative. There's a real, I think, focus on quantitative data, and rightly so. And there's a, once upon a time, a reasonable statistician anyway. I'm obviously a big fan. But some of that qualitative data, for example, understanding how the local population feel about these kinds of things, is incredibly important as well, bringing those together. And this interpretation point, so I said underpinned by analysis and interpretation of data, is really super important. That is the interface between analysis and decision making. And in my experience, it's where it often goes wrong. It's not because we're short of data. It's not even necessarily because we're short of analysis. It's because we're not always particularly good at translating that to be relevant to a decision that we want to make. That might be because the decision question itself hasn't been effectively communicated or put in an analytical way. Or occasionally that decision may have already been made and the data doesn't back it up as we might be desired, so we just kind of ignore it and shuffle on. So fundamentally, I think that the semi-permeable membrane that I mentioned between evidence and decision making is one of communication and translation. So how do we make that interpretation better then? Can I have my next slide, please? Sorry. Firstly, we've got to make sure we're speaking the same language. We often find ourselves perhaps thinking that we're talking about the same thing, but not necessarily using the same words. This is a neat little, if you indulge me in a little story, my niece came to stay. She's from the Northwest, and she refers to a balm, and I cannot describe to you the bafflement with which her paternal grandfather, on his face, a Londoner by birth, what on earth is a balm? I've never heard of this before. So only on a supermarket trip did he kind of realize actually she was talking about what he would call a bread roll. And that term baffled her equally. I mean, to be honest, she's only 3, so that's not unreasonable. So they were talking about the same thing, but different terms, complete confusion. Oh yes, and she's 3, so obviously she's allowed. So both analyst and decision maker both have a role, pun intended, to play in improving that evidence and decision-making interface. Both sides, if you like, should be prepared to take time to really fully develop good questions in terms that are meaningful and relevant to everybody involved. So, and in my world, particularly at the moment in evaluation, we spend a lot, and I do mean a lot of time with the people we work with to really understand what they really need to know and test that exhaustively with them. Otherwise, obviously, we risk designing evaluations and analysis that provide answers just not the ones that people actually need to make the decisions about should we scale up this particular new innovation, or has this new teledermatology program worked in the way that we anticipated. So this early and open communication is absolutely at the heart of improving the analysis decision-making interface. And obviously it helps to build trust as well, meaning that analysts, people with analytical expertise, can add value to the decision-making process itself through expert interpretation and not just be the purveyors of spreadsheets and p-values or whatever else we're looking at. That's obviously a two-way street, which is why the bullet points on this slide are basically the same from both the analyst perspective and from the decision maker perspective. But there are a couple of specifics as well. I think analysts need to be really honest and upfront about what can or can't be done with the data available. We know that it's not perfect. We've got some great examples in some of our work at the moment when we're focusing on health inequalities, and actually we just don't know some stuff because the data quality for elements such as ethnicity at a really granular level is relatively poor. So we may not be able to answer all the elements of the question, and decision makers need to know that sooner rather than later. And then equally, decision makers, if they really want to be data-led, need to be prepared to hear things they didn't expect, and in some cases didn't want to. Again, we've had some interesting experiences where an evaluation hasn't gone quite as expected, or at least the results of that evaluation hasn't been as expected, and we've been asked to revisit or get more data in the hope the numbers would magically reflect what everybody thought that they knew already. Can I have my next slide, please? I wanted to give you a very brief example of how we've tried to address some of these issues at UCL Partners. Now, UCL Partners is, among other things, an academic health science network, so it doesn't have a direct care provision role. We're a health innovation network and have and we want to support our partners in the kind of big strategic decisions that they need to make. And part of that, not just by itself, it's part of an ecosystem of support and around insight and evaluation. Sorry, excuse me. We developed a publicly available insights platform. This is not reinventing any wheels. All the data is already out there, it's public, and it's available to all. And the value add is, don't get me wrong, I've got some beautiful snazzy visuals. I will show you a couple in a moment. But the real value add is primarily from the curation of a blinding number of indicators that are out there in lots of different places into something that is hopefully visually appealing, easy to navigate set of indicators that reflect the priorities, meet the needs of the local decision makers when it comes to having clarity on key priority areas. I'm going to give you a quick example in relation to health inequalities before I run out of time, which is from the Explore Our Population section. So this is a screenshot of the jumping off screen for the Explore Your Population section, and we have other sections, so challenges to address, which dives into specific disease areas, for example, and then we've got a tracking progress, which is where we're looking to see whether there's change over time, etc. So I'm not going to go into all of that. I'm just going to give you this example in relation to health inequalities. Can I have my next slide, please? So in consultation, and this is the key point, in consultation and discussion with some of our partners, we started to develop visualizations, including some of the things that you'd absolutely expect. So, for example, the ethnic profile of our areas, which can be broken down by ICB or London Borough. This particular one is for North East London ICB. And then we've got the proportion of people living in the core 20, who are living in core 20 LSOAs across all of the London boroughs and the local authorities in Mid and South Essex, which is part of our patch. And you can see the enormous variation. We can drill into that a little bit more. We've got some life expectancy stuff in there as well. What's driving the life expectancy gap between most and least deprived? All of these visualizations are in there. These are the things that people wanted to know. But something that came back, and we probably would have put that together if we'd just sat in a darkened room and thought about it. But one of the things that came back to us from our initial discussions with decision makers, can I have the next slide, please? So feedback from stakeholders and also local research was actually one of the biggest barriers to access in healthcare is English language proficiency. And given that in some parts of our geography, which is obviously hugely diverse, particularly in the North London area, we've got parts of our geography where the proportion of people who don't have English as their main spoken language is over 30%. So having insight into that is absolutely critical when it comes to thinking about how you're going to develop services, the kind of provision that you might need to put around them to ensure equitable access, for example. So this is North East London again, where 24% of people who live in the ICB have a language other than English as their main spoken language. And we can start to drill into that. This is a very kind of simple, you've got the overarching view there on the left, and on the right, you've got the drill into the non-English languages. Huge diversity in that 24% with a mix primarily of Romanian, Bengali, Urdu, Spanish, Punjabi, Bulgarian, and so forth. This is one of our most popular visualizations. It's really simple, but quite impactful in terms of starting to really understand the needs of a population and some of the actions that might be needed to be taken to address the inequity that we know people who don't have a high English language proficiency experience in terms of their barriers to healthcare. I'm almost out of time. I've got one more slide. Thank you, Danny. Fantastic. This is just my final point. If you'll just allow me a painful analogy. You've allowed me a lot in this 10 minutes, stories, painful analogies. Making high quality decisions with data is a little bit like test cricket. It's a team sport that doesn't always lead to a clear result. And this is where it gets really painful. You need a field of good questions, analytically appropriate and well framed. You need a multidisciplinary team, and I'm sure that the next speakers will demonstrate this beautifully. So analytical skill, data curation, data engineers, whatever, clinicians and decision makers as well. And then finally, you needed the sun of curiosity to shine down on you. And obviously in test cricket, you need that for 5 days. You don't need it for that long when you're trying to make decisions with data. But that curiosity and a willingness to explore together utilizing data is what absolutely underpins making good decisions. And there's a fantastic couple of comments coming up, which I think will hopefully reinforce my painful analogy. It doesn't always lead to a clear result, and that can be frustrating, but I think we all know that we work in a really complex system, and being comfortable with some of that ambiguity and iterating it and acknowledging that being data driven doesn't mean a black and white data says this, therefore. It actually means a conversation, and a degree of translation will transform how we make good decisions for the populations that we all aspire to improve care for. That's it from me. Hopefully I'm on time, Penny.
Yeah, perfectly on time and gripping
Great.
throughout, although one member of a sport obsessed family, and it leaves me cold. You lost me at the end, but clearly not other people in the
sorry.
chat. We have a question in the chat from Shane Gordon, an invitation to others to add questions in the chat for Kate. I'm not sure if you can see Shane's question. He's asking about how complete the data set is for the languages and the data source for that.
Data source for that is the census, so it's as complete as the census is, which is reasonably good. We've done little bits of work in more localized areas where we've tested some of this, and it is broad. From what we found, it is broadly a reflection. What we found is a limitation is that this is obviously people's self-identified kind of main spoken language. So there's a couple of nuances in there. Firstly, it doesn't necessarily, so even if your first main spoken language is not English, it doesn't necessarily mean that you don't have proficiency in English per se, or you may be good enough, and also it's spoken. One of the barriers that we found with local research is that whilst people may have good spoken English proficiency, they're not necessarily very good at reading English. And the NHS, unique amongst organisations globally, still communicates by people with written letters. And certainly, and a lot of people report struggling to understand what a letter means and what they then have to do. And given, so appointment letters, for example, you have, if you don't phone this number by then, we'll assume you don't want the appointment. Those kinds of letters that you get, and often they feel that those instructions aren't necessarily clear to somebody who doesn't have good reading in English, if that makes sense. So it's by no means, Shane, a kind of comprehensive, kind of gives you everything, I think, but it's an excellent indicator and jumping off point, and that local, particularly qualitative, if I'm honest, research has been really useful for us in kind of getting underneath some of the issues for specific projects and programs of work. I hope that's helpful.
Great. Feel free to come off mute if you'd like to build on that. James, I don't know if this is a comment or if there's a question in there. For Kate, do come off mute if you'd like to ask that. In the meantime,
I mean, yeah, I've just read the comment. So for what it's worth, I agree completely. And although we in theory have the opportunity under law to access our notes and make sure that our data is correct, it's really not very easy to do that. So by utilising NHS app or if there's something different in Scotland, Wales or Northern Ireland, it makes so much sense. I mean, we do it in pretty much everything else that we do in life. I'm not quite sure why we haven't quite managed to pull that all together for our healthcare. So yeah, I completely agree. I think there's huge opportunity there. But we obviously have to think about digital inequality as well. It doesn't necessarily suit everybody, but I think for the majority.
Great. We've got a question here about how to help decision makers who are not data folk better commission data experts, so that we avoid getting too lost in the numbers.
Yeah, I completely agree, and I don't have all the answers for that, but I think there's two elements. So I kind of appreciate that there's not really at the moment a defined career pathway for analysts. I said I'd get that in there. But if there is, I think training in how to help people develop their questions better is one aspect of that, from the analytical side into the decision maker side, and communication. I would take a good communicator who needs some more training in analytics than I would someone who's got all the analytical training in the world but can't communicate. So there's some really kind of basic things that we can do as an analytical community to support this, and some of that is very visual, without sending someone a pivot table in Excel, for example, is not a provision of insight and intelligence. It's just giving them a kind of slightly aggregated and summarized version of the numbers. It's that interpretive piece. Analysts need to think about that. That's what the analysis is. The rest of it is just chopping data into bits. What does this mean? On the flip side, I think whether it's clinicians, whether it's managerial colleagues, being curious about what you are sent by your analyst is a really key piece. What does this mean? And if you don't understand what it means, ask the question. It doesn't mean that it's wrong. It doesn't mean that it could be that they've misinterpreted what the request was in the first place. So just to be kind of really short about it, it does really come down to that communication, and that communication not just of the question but of what you need back. So if you're not a numbers person and they leave you completely cold, say what I need back is a 3 bullet point summary of what your findings are, or what I need back is an infographic of what this means for this ICB. That's kind of just some thoughts. Again, there's lots of ways to approach it.
Fabulous. We'll be coming back to Q&A later. I'd love to get into perhaps the particular kind of equity dimensions when we're thinking about that data and decision making interface. But why don't we move on now? Can I check if we have Mark with us, and whether I should be handing it in first, or whether I'll go to you first, Jack.
Hi, Penny.
Thanks, Penny.
Mark is with us, but he can't hear and he's still having some issues. So I think, yeah, straight to Jack, if that's okay for now. Thank you.
Brilliant. I'll hand straight to you to introduce yourself, Jack.
Absolutely fine. Thanks, Penny. Hi, everyone. So a quick introduction. My name is Jack Dunne. I'm a programme analyst looking at elective care, working for the West Yorkshire ICB, but within that, working with WYAAT and the elective coordination group, which is a collaborative looking at how best to coordinate the response to elective recovery. So within that, there is a data element that we've got. It's also a very sort of close collaborative. I think it's important to actually, can we put this first slide up and then we'll can go through there. That'd be great, thank you. And a couple more. Yeah, so if you just go one further on. Right, massive wall of text, but that should hopefully help me go through what I was going to say, minus the introduction we're going to have. It is using data, but I think it's what we'd probably be looking at here is it's a case study of using it in quite a sort of operational heavy way. So the elective coordination group has got it's a broad group, but with quite a clear focus. The idea being that it's there to support people from the providers, operational teams from providers, and interested stakeholders there kind of come together and talk about the challenge. So it's really trying to foster the sort of spirit of cooperation, of honesty, of trying to help out. So that being the kind of driving ethos of what we're doing, the role of where we've used data to this point and by design has been to supplement that. So in some ways, I just want to pick up actually something that Kate, you said towards the end of to respond to one of the questions. Sending someone a spreadsheet isn't really analysis. It'd be good to get that kind of interpretation. You need to actually use it. So what we're doing is actually sending people a spreadsheet, but what we're doing is having a very regular contact and having feedback from people who are actually at that sort of live sharp end of what we're doing. So we're using the waiting list data, we're using the SUS data, so it's commissioning data sets, which I've got access to, and used as part of the ICB. But it's bringing it to an audience where there's an operational concern. And that means that by having that as a kind of established, regular, trusted, and neutral in a sense, because it's coming from a separate party, it's not coming directly from the providers, it's there as something to sort of shape discussions, to inform discussions, and to kind of keep an eye on how those really kind of clearly defined tasks of reducing longer wait is happening. So, for example, that would be, if you were able to look at the data that was coming in and see if there was an opportunity to provide mutual aid. It seems quite straightforward. It would be useful that teams from constituent trust could ring up and said, we've got a problem here, can you help us out? But by having a forum which is kind of underpinned or supplemented at least by that waiting list data, it kind of shows people where they are and allows them to check in. So over time, that's kind of generated a shared understanding, of how we're going to approach those issues. I think it's sort of mentioned, but it's really important. It's not an integration of what's happening at trust level, but that is much more embedded. It's much richer. It's operational. It's performance management. They've got their own teams who are doing really important stuff, really good work, and a lot more detailed work. I think probably trying to borrow into some of those concepts that you were talking about, Kate. But what it has allowed us to do is to surface that. So it's where good work is being done. We've now got a group where that can be surfaced and at least shared. So it's been a kind of iterative process whereby we start with using data to get a relationship going, and then because we've got that shared language, we kind of allowed to bring people in, but with a shared understanding of how it's going to work. Can we just pop onto the next slide, please? So this is just an example of one of the shared data packs that we do. So it's a weekly pack. As I say, it's just using the commissioning data, but again, it's pulling it into a format that everyone can see, that's regular, that is kind of expected. So just put a note on the side there. So it's got quite a broad mailing list, so with some of our system partners, and therefore it's there and it's recognised that it's coming out. So to some extent, it is similar to some of the information you would get possibly from the regional NHSE team, or you could get played back to various boards, but it's coming directly from our smaller team within the ECG, and kind of showing where we've got to. It also gives them assurance, so that can sometimes go back with, if you've got direct operations or people in the ECG, they take that back and play it back and say, this is what we look like in a comparative way. So it's not digging too far into what's happening, but it's giving you that idea of what this data play is. And again, it's just something that you can keep playing back, holding up a mirror to what's happening. Just pop onto the next slide, please. Thanks. So this is just an example of one way that we drill down into it. So as I say, the primary concern, or one of the sort of key thing that we're doing, is looking at reducing those longer waits. So this is just a visualization that we've got that goes into some of the packs we produce that shows, we've used ENT as an example here, but it's just showing how that list is developed, where that might be. And again, you can see if there's a different story, a different provider, it's not necessarily what we're doing to dig into that and say, well, this is why, but we do have representatives from all those providers who might look at that and say, well, yes, this is exactly what's happened there. So if it's something that looks like a success, they could share best practice. So whether that's to do with something that they're doing in theatres, or something that they're doing in terms of triage or kind of data validation. Similarly, if there's something where it looks like there's actually an operational challenge coming up, we've got the means to kind of have that discussion there and say, well, we can see these numbers. What can we do to help? So it's kind of course corrects. And just to say, with that kind of operational support element in place, we've also kind of tried to take some of these concepts. We've been asked to look into the pediatrics, which is being recognised as becoming a sort of pressurised area across the patch. So because we've got these concepts, because we've had the discussions, we've been able to sort of expand that to that. And it's not that the data is going to drive that discussion, but it's there and it's familiar. And some of the people who are going to be involved in those conversations will have that as a sort of some sort of basis and understanding of how we might look at it. Just pop onto the next slide, please. So I'm going to get to health equity eventually, having just gone through how we're looking at long waiters. I think it's important that we kind of qualify this a little bit just by saying that we have been looking at reducing long waiters. That is the narrow focus, but the primary focus. But within that, there is an understanding, and it's a shared understanding with all of our system partners, that anything that we do shouldn't be exacerbating existing inequity. Now, obviously, deprivation quintiles are problematic as you get down into the detail. But as an overview, what we can do is just check that there's nothing really kind of it sticks out that's something that we've exacerbated. So this view is just looking at how the numbers track over the course of the past year or two, how that split breaks down into the quintiles. The next slide, please. Same view, but just a little proportion breakdown there. Now that proportion roughly mirrors what we see in West Yorkshire. So in and of itself, it's not saying anything revolutionary, insightful. But it's just tracking that there's nothing that we could be doing that we would need to look into. But again, specifically, is what we are doing is trying to reduce long waiters. We're trying to treat patients. We're trying to end pathways where appropriate. We're trying to refer people onwards. So it's really just keeping an eye on that. If we go to the next slide, please. Sorry, could you have the next slide? Great. So this is just revisiting, sorry, one back. Oh, I can speak to this one. This is just looking at how those how those long waiters how that's developed. So the successes that we've had in terms of addressing the issue of the long waiters, just highlighted that on that chart there. So actually it's a breakdown of where the patients in the list are waiting in terms of how long those pathways have been open for. So it's showing an overall growth. It's also showing that where that change has happened over the past year or so. Then, so you can see towards the end of that list, that's come down quite drastically. At the start, waiting under 26 weeks, as you'd expect, that's not grown quite so quickly. But then that middle section will be a cause for concern. Could you just pop onto the next slide now? So that's the longer waiters, and again there you can see, so in the green and in the orange, those are where we've had those targets to try and reduce those longer waiters. that's the 104-week weights and the 78-week weights. And over time, we've seen that those have come down. So the next slide just repeats that process, but again, looking at it through that deprivation lens. So we can see that's the full list, that is the full growth, and you can see that it's grown relatively equally between the 5 quintiles. So again, it's not universal, it's not sort of fundamental, there is no inequity, but it's just saying that there's nothing glaring, and that's repeated as we drill down into specialties or across places as well. Then the next slide, I think that probably illustrates what we're saying, I suppose, to the greatest extent, is that where we've been tasked with reducing those long waits, because it is a universal thing, it's reducing what was an equally sort of distributed very long list to a list of very few. So it's where we started looking at issues of health equity, but also because the focus has been on reducing the long waiters, the headline stuff, the headline data that we're doing is just monitoring that. So just pop to the next slide, please. So because of that, that will require a few qualifications and what we're looking to do. So it's a high level view, it's by design, so we can look at the overall picture and possibly highlight areas that are interesting to drill into. It's focused on the end of the pathway. Again, that's by design, that's where we've looked. So it's after referrals, once a patient has accessed the pathway. We're also looking at those pathways coming to a close, so where there would be issues that we might want to go further into in terms of how easy that access has been or how equitable, whether there have been issues that are affecting certain patient groups. That's not what we've had the primary focus on, but what we have done, as we go back to what I was saying at the start, is that we've fostered this idea where we've got sort of honest, open group of interested and sort of important stakeholders who can then take that back, but also take that learning, take that kind of that process of working to groups that are growing out of that. So that's outpatient transformation we've got a very close relationship with, and that takes in some of those issues around access, around where there might be different rates of DNAs, where there might be issues in getting people to access perioperative pre-assessment. So the work in that sense is to come, and that will be done at a different level. And also we'll be using different data. You know, we can't address some of those complex issues using commissioning data. So where we've had successes with commissioning data, and it's been part of forming and kind of developing a really kind of productive and successful collaborative, it's given us the opportunity, I think, to kind of consider what the future challenges might be. So where we actually need to kind of drill further into those issues. But it has given us a platform where it's got the right ethos, it's got the right kind of it's got that idea of a collaboration, an honest collaboration, and an idea that people can bring people into that. So it's iterative in that sense. We've been asked to cover more, and as a result, we'll necessarily have to go deeper into that. And that is very much something that's a future challenge, but we're also quite well placed, I think, to do that because of sort of what we've developed kind of culturally. So I think that sort of brings me to the end of my slides. I'm sure Mark, if he were available, could be, but we'll proceed as though he's not here and maybe move on to some questions. So just pop into the chat and have a look at those. Oh, hi, Penny.
Great, thank you, Jack. Let me just check if Mark is with us. Mark, please do continuing to join us. Try to join us. In the meantime, if there are any reflections you'd like to add in the chat, that would be that would be great. And to others, please do chip in with questions. Shane, we have a question from you in the chat. So wondering about the changes in service model or location that have been driven by the inequalities analysis. What has the impact been?
So I think I would probably come to my point of it being what we're doing is we're at the start of the process, and in terms of formalizing that, where we're able to use the analysis to do a formal intervention to then have an evaluation of that. We're not necessarily at that stage. What we do have is a kind of, for example, some of the best practice that we've shared. So there have been it's things that are as simple, I suppose, as just interpretation of RTT rules, interpretation of triage, that type of thing. That they've come up organically in conversations that, oh, this is an issue that we have. We've looked at another trust of a different population, and they've adopted that, and that has been borne out in the final data, as it were, which is a reduction in either waiting times or long waiters. So it's also an informal evaluation. I'm sort of acutely aware of that, but it's not kind of a full sequence. But it is, there are elements sort of organically coming out of tailoring responses or changes in service provision based on the different types of population and location that we've got within the system.
Thank you, that's really helpful. Mark, I can see that you've joined us. Are you able to come off mute and see if your audio is working?
I hope so.
Perfect.
I really am so sorry. It's just been I could see you all, and I could lip read Jack, but and yourself, but I'm really sorry. The audio just wasn't working. Anyway.
Well, you were just building anticipation. Why don't we go to your presentation now, and then we'll continue the Q&A. So yeah, over to you, Mark.
So it wasn't really. It was kind of it was linked in with Jack's. I think this is a tricky presentation to put together because the title was data-driven evidence for managing health inequalities. And of course, I think you've seen how we manage data generally through WYAAT. So I don't know if, because I couldn't hear him, I didn't know if Jack had actually spoken about what WYAAT means. It's much in the same way as this, the collaborative that you've brought together here. We're a collaborative in West Yorkshire and Harrogate. We have been going for several years. It started as a group of individual trusts with individual ambitions, if I'm honest, and the aim, which was really primarily put forward by Julian Hartley, who I think is the collaborative boss, chief. He decided and really persuaded his colleagues as chief executives across West Yorkshire and Harrogate to join a group. And then the medical directors were invited in. And from that kind of nut of an idea became the oak tree of WYAAT, which is essentially a group of clinical networks held together by a management group. And I'm sorry that I haven't introduced myself, but I will do in a moment. Clinical network, so it's a clinically led collaborative which will bring together best practice across all trusts. Now, and this is not to say that we want all trusts in our group, which include Harrogate, which I've mentioned, Leeds, Airedale, Calderdale and Huddersfield, Bradford and Mid Yorkshire. So we're not asking everyone to do the same thing. What we're asking them to do is to look at best practice across their piece. And there are some excellent examples of good practice clinically. And then our aim and ambition as the WYAAT, I suppose, program group is to facilitate that. Now, that's not always easy because clinicians don't always agree, managers don't always agree, people don't always agree, but it's about bringing those good ideas together and actually seeing it in practice. So what we do for that, and have done for, as I say, several years, is a weekly meeting, and I think Jack will have mentioned this, our elective coordination group meets on a Thursday evening to discuss particular problems in terms of patient care, patient number delivery, and then how we can help each other. So there's a very specific element on that agenda called mutual aid. And we then ask each individual trust, where do they need help and how do other trusts help out. So I hope Jack showed that we are, whilst we don't have a specific remit for health inequalities as a group, what we do recognise are individual trusts that might need help in accessing additional help, and that might be through mutual aid through our own organisation or through independent sector, or it might be from outside providers. But essentially it's very open, and whilst as you can imagine, the initial few months were a little kind of guarded, I suppose is the right word, in terms of sharing your own problems and sharing your dirty laundry. It's really become a very open organisation now, where nobody is concerned about saying, I've got 2,000 long waiters until till the end of March, and and I'll be honest, that's Leeds, but it's then how do we all get into that? Now, health inequalities is a specific point about this meeting. I think you're going to hear from our chair of our WYAAT elective coordination group, Russell Nightingale, in December at your follow-up meeting to this, which isn't so much about data, but it is on a similar topic. So some of our trusts have really good examples of working and identifying, I suppose, groups of patients who are requiring additional support in accessing healthcare. And whilst and I'll bring out as a specific example, that's Calderdale and Huddersfield Foundation Trust, and that was really pushed forward by their chief executive, and continues, and it was supported through their information systems, which were able to record and identify patients as they came through. However, the principle for our organisation is that we treat everybody equally, and whilst we do accept that there are some people that are requiring additional support, the digitally less able, for example, and those that require help because of their long-term conditions, etc. What we try and do, and I think Jack has shown on his graphs, is that we have a very tight rein on all people. So in terms of access to healthcare and driving down waiting time. So we don't have a saying for it, but everyone is equal until they're unequal. And also the other way around, everyone is unequal until they're equal. So it is very difficult to say we have a specific program, which I think also Jack will have brought out, to identify groups. And this is made more difficult by our technology, which I'm sure many of the people on this call will recognise, that there are lots of different patient management systems. There are several within West Yorkshire that don't talk to each other. Those that do make the job of identifying and promoting health inequality levelling is much easier if you're able to speak through these systems into primary care and into secondary care. So System 1 is a perfect example of that being able. Others like PPM and EMIS just really don't speak in a two-way system. And I'll give an example of one of our trusts where we had a patient management system where we only had one more field available on our system that was able to be used for anything, and we chose to use it to identify those that had particular requirements, and but we weren't able to then dive down further simply because of the technical kind of deficiency of that system. So in effect, we have a very good working relationship with our local trusts. Obviously, there are differences of opinion, and so I I would regard us as a collaborative, much as you are today. And whilst we don't expect everyone to do the same thing all the time, we do ask for a consensus, and then, if you like, add appendices to any of our guidance, which then specifies how we differ. So I hope that is a kind of, and I'm so sorry about the audio problems, but anyway.
No, thank you, Mark. That's really helped bring alive some of the kind of technological and relational kind of challenges that we might have with doing this work. Great. So is anybody who would like to come out of that group discussion with a question for our panel, or indeed a comment or reflection from your conversation? Please come off mute and share that, or you can share in the chat. Oh, looks like we still have a couple of groups coming back in. Kazim, we've got a question here about how we're actually looking at making systems connected and assuring we're all interconnected. Again, I'm interested in whether that's on a technical level, or whether it's about the relationships and broader decision making to make informed decision and data-driven decisions that are data-driven. I don't know if anybody would like to respond to that. Maybe we'll take a couple of questions. So I'll come to you, Angie, and then to you, Shane.
Don't mind giving a bit of insight about our discussion at the trust that I'm at, which is Ipswich and Colchester Hospital, isn't it? We've actually started this programme of work. We've had a health inequality strategy approved in January this year, so we're a little bit further ahead than others. And I just thought, because I was in a group with someone who is starting out on this work, it was useful to discuss what the barriers might be. And so some of the things that we talked about is that the changes in the system, like within the ICBs and things, are causing a bit of, you know, uncertainty around, you know, who's going to be around to do this work. If we're doing collaborative relationships, will we be able to continue with that work, and will it potentially jeopardize the work that we're planning? And the other thing that we were talking about, of course, is the classic, given the sector we work in, and money to actually execute it. Because, you know, we'll find that when we're having these sessions, there's lots of really, really terrific ideas, but one of the pitfalls is the resource, the financial resource and the human resource to deliver. So being ambitious, but getting that balance between, you know, what's realistic and achievable is, you know, has been quite challenging, definitely.
Structural changes and resource constraints. Yeah, we'd love to hear the reflections of the panel or others on that as a barrier. Shane, should we bring you in first and then turn to the panel to respond?
Thanks. I work at the same trust as Angie. Interestingly,
Great.
I think we've made great progress over several years on this, not universally across the board, but in specific areas. So I was sharing in my group 2 particular areas that we've focused on, which are diabetes, where there are massive impacts from inequalities on outcomes and access to services, and in the selection of location for our community diagnostic centre in Clacton, and the analysis of the impact of that centre. So that one's a more complete, I think they're both fairly completed loops in terms of PDSA. And the data there is data that's integrated from System 1 in primary care, has been for 4 years for diabetes. It's, you know, all of our practices participate. We've got great support from our ICS in providing the integration for that data and the data visualization through Power BI. It's updated on a monthly basis, pretty much in real time for that sort of condition, that we use as a feedback mechanism in our collaborative ICS diabetes group, so that we share best practice between the areas. We've got, as a result, some of the best diabetes performance in the country from some of that work. So, you know, some real impact, as well as just, can we get the data? And it was a bit, I confess, a little bit of frustration in the earlier presentations, with a bit of slopey shoulderedness, I have to say, in terms of getting on with this stuff.
Thank you. Let's turn to the panel to get some reflections on that. Kate, can I come to you first?
the kind of, well, I was in my mind, sorry, I was looking at the chat and going down a data sharing kind of reflection, and it's certainly something that we talked about a bit. I think I had a really insightful chat yesterday with looking at a piece of work that's basically implementing a mental health hub access via 111 Pan London. And one of the big issues in terms of getting this working has been data sharing, and it's come back up again and again. And we reflected on how did we manage to get all of this stuff done during COVID when we had COPE in place? Why have we gone backwards? What's the issue here? And fundamentally, the problem is because everyone had a slightly different approach and different sets of kind of standard operating procedures. And I think there's one of the Nia's comments saying people are often scared and have concerns with GDPR, etc. I think there's varying appetites for risk, and there's always risk with sharing data. And we are by nature quite risk averse, I think, in the health service. But one of the things that came up yesterday was that it's taken time and trust and the development of good relationships to standardize data sharing agreements across. This is taken all, there's 2 hubs and it's basically across 4 providers off the top of my head. They've standardized their data sharing agreements, and it's like, as it was described to me yesterday, it's like literally someone has just turned the key in the lock, and it's, you know, things are flowing, the data sharing that's required. And, you know, let's be clear, for a direct to patient service, it's not secondary uses, someone wants it for a bit of research or something like that. This is for provision of care, but that it's taken maybe 18 months, but it's the trust and relationships that underpin that that's enabled the standardization that's unlocked it. And I think some of the principles of how that's happened in that particular program of work is applicable equally to some of the elements that Shane was talking about as well, in terms of bringing, you know, getting all of your plumbing in place so that you can actually undertake analysis on data rather than worrying about how you flow the raw material, as it were. But I hope they were useful reflections. Sorry, I was busy reflecting on data sharing rather than paying all my attention to Shane.
But perhaps to kind of link that to the other questions that came in, I mean, that slow progress of getting to the point of data sharing, is there, once you've got to that point, can you share that between places, or does it rely on developing those relationships and working through the detail in each individual site? And given that takes time, do you have any tricks with managing that in a context of structural change and resource constraint?
I mean, in terms of resource constraint, in my experience, we're very, very fond of reinventing wheels in order to make it our own. So avoiding some of those behaviours and utilising stuff that's out there that's good enough already, rather than reinventing the wheel. I don't think I've got any kind of really top tips. It's about people and relationships in my experience, which is a kind of really trite thing to say. But build these kinds of networks. We're kind of making the difference now by being involved in these kinds of networks and having this kind of cause and being really open and sharing what works and what hasn't worked. And I'm not going to say go as far as say embrace failure, but capitalize on it. If something doesn't go well, share it and share it widely, even as a cautionary tale. But we're all improvers on this call, I guess. So I'm preaching to the choir. That's difficult.
Well, I think we may reach a wider group than people who would necessarily identify improvement as their burning fire, their professional lives. But thank you, Kate. I wonder whether there's also a reflection from your talk about that connection and relationship with decision makers, and if you've built that relationship of need and kind of genuine connection, then it might help you get the sponsorship and support you need to ride you through this work, which takes some time.
Absolutely.
Great. Jenny, I'll come to you, and then I'll ask the rest of the panel to respond. So Jenny, and sorry, Jay Lancaster, I'm not sure of your first name, but we'll come to you next.
Thanks, Penny. I mean, this is just just taking up to the board level, actually, rather than specific on data sharing, because I particularly wanted to ask you, Mark, because one of the things that is clear from the first presentation is just the importance of the decision makers asking the right questions around health inequalities data to really inform decisions. And I just wondered how much work there'd been across at the WYAAT Provider Collaborative Board on, really to speak to the point from Joanne about alignment around your priorities for health inequalities, because it's such a large agenda. What are the kind of key things across the collaborative that you're working on, and how you then interrogate the kind of health inequalities data to continue to drive that prioritization piece? Has that been something that it feels like it's been a real priority at board level across WYAAT?
Shall I come back on that, Penny?
Yeah.
Yep.
Yeah.
It's interesting because I think, to be honest, we haven't focused specifically on health inequalities as a WYAAT group. Our reporting mechanism is fairly linear. So, the WYAAT operational group, of which I'm part, will report to our medical director group, who will then go to our chief exec group as part of WYAAT, and then decisions in terms of prioritization will be made by those the kind of executive, if you like, of those of WYAAT, but then to take back into the individual trusts where and obviously they require information, don't they? So going back to what Kate was saying about data and how useful that is. Well, clinical activity drives data. Data then directs clinical activity, doesn't it? So it's not quite circular, but it's certainly backwards and forwards. So the priorities that are pushed forward through from our group towards the chief execs of the individual trusts include things like health inequalities. We've heard about diabetes from Shane, areas of real concern, and where we get that information is from our clinical networks. So we have representation from every trust on almost every clinical condition that you might wish to have representation from. So obviously in my area it's mainly elective recovery, but not essentially. It's a group of clinical networks that are growing organically, because elective care, you could almost argue, is almost everything apart from those that walk in through ED or through your kind of urgent care centres. But essentially we ask our clinicians, what are they worried about? We ask them to report back to us on a weekly basis. So we ask our clinical networks to report back to our elective coordination group on a Thursday afternoon by rotation or by exception if there's an issue, and they will report to us what we need to then put up to board level. So, effectively, we would expect our, that kind of reporting mechanism going up through MDs, then CEOs, will then inform the boards. So does that answer the question in a roundabout way?
Yeah, no, it's helpful. It's helpful, Mark. Just that kind of dot joining, isn't it, between the kind of, what's happening at the different tiers and how the board
hear about
that alignment. Yeah, the alignment and the kind of prioritization around health inequalities and how it gets embedded in all that the collaborative is doing.
Yeah, it's just a reminder of the understandable kind of complexity and scale of the number of levels of the systems that you're talking about, and that I don't know if that's a challenge in terms of having clarity of decision making and sense making and ambition around this agenda. But yeah, Joanne, let's come to you.
Yeah, thank you. It follows on a little bit from what Jenny was talking about. I'm a non-exec director on a community health foundation trust. Relatively new to the NHS, so I became a NED in February. Prior to that, I was in local government as an executive in local government, well, for 35 years. And one of the things I've really struggled with in sort of unraveling in trying to get through some of the data processing things from an NHS perspective is the whole commissioner-provider split. Because it's very easy as a provider to say, oh, well, it's the commissioners. And it's very easy for the commissioners. And the whole ICB thing just from a local government perspective, from my previous existence, everybody assumed that the ICB was going to make a massive difference and ICSs were going to transform the old commissioner provider split, and it doesn't seem in reality to be working. And it was just a reflection of, is that just the system I'm in, or is this generally still those tensions between national direction and local discretion, and the strength of commissioners and providers to genuinely collaborate about what needs to be done and how it should be done?
Thank you. I
Sorry,
don't know
that was a bit of a ramble, sorry.
Oh, it's a very, a very helpful reflection, and something we hear often. There's also perhaps relates to the question of how quickly might we expect some progress at ICS level led by the ICB, and where's the role of provider collaboratives, particularly recognising they may be building on pre-existing relationships. Mark, I don't know if you put your hand up to respond to that point. Should I come to you next?
Yep, thank you, Penny. And this organisational describing, Joanna, is a real problem. And what we probably haven't made clear in West Yorkshire to the panel or the rest of the group here is that we have negotiated a different payment system. So we remain on what's called an aligned incentive contract. So as a group of trusts, we no longer are bound by payment by results. And so we have agreed a certain amount of activity across all trusts. And this is obviously has huge oversight from NHSE particularly. Whereas the rest of the country have gone back to PBR in April, we continued with an aligned incentive. And that actually takes away that competitive edge that does cause problems in terms of providing care. If one hospital says, right, well, we'll take all the orthopedics, for example, and we'll absolutely make a mint from that particular group of patients, that then leaves others struggling a little bit if you're working in a collaborative model. So we have this aligned incentive contract. Obviously that, well, not obviously, but it does include specialised commissioning. So some of that dilemma is taken away because it is a collaborative between commissioners and providers, because everyone's looking to actually deliver what you've promised across the whole system, as opposed to just in one individual trust. Although obviously there are individual trusts that require additional help, but that's when mutual aid comes in from our neighbouring trusts. So we've also everyone will have noticed that ICBs have been kind of pruned near the root, 30% job losses, etc. And they've only been in post, those particular people have only been in post for 1 year. ICBs were, for those around the room, of a certain vintage, of which I am one, very similar to regional health authorities. So, not very different. But suddenly, they're being pruned back. And for us, many of their staff are coming into the WYAAT collaborative, to kind of bolster that. And that includes GIRFT. So a lot of the stuff about GIRFT and high volume, low complexity work is being brought into our group, call it what you like, but so those same people that you kind of you regard as overseeing provision by being commissioners, we've kind of blurred those edges slightly.
Okay, gosh, there's such rich learning from the different contexts that we're in different places. We'll, learn with interest from what you're doing. And we're nearly at the end of the time we have available. Shane, can I ask for a brief question or comment from you, and then?
Well, it sort of follows on from what Mark was saying. This is all about leadership. It's all about will to work together in the interests of our community. And I think what you're hearing from Mark and my own experience locally is we have a high trust system. And when you have a high trust system on a human level between the leaders, actually all those barriers that people are citing in the chat go away. You know, we've got back-to-back data sharing agreements. The data flows easily between commissioners and providers and providers and providers, and even between local government and health in some cases, heaven forbid. It's all about leadership and will. And if you're not getting it, you need to advocate for it, because we lose focus on what we're here to do otherwise.
Thank you. Gosh, what an inspiring way to wrap up. I think I'm really keen that you get away on time from this session, so I'm going to close it there. I think that was really helpful. Just to say a few kind of final words. You know, thank you very much for joining. If you are happy to kind of keep in touch with the other attendees from this session, if you pop your email in the chat, that allows us to make sure we you know, share your details with permission. It would be great if you can help us to learn by completing the evaluation. There'll be a link in the chat and a QR, there's a QR code there that you can feedback to us on. That'll help us really make sure that we're focusing on the kind of key hot topics for you. Certainly from this conversation, I'm picking up on some things that would be worth discussing further. We do have more upcoming events, so just to flag a couple. So focused on creating an enabling environment to improve equitably on the 18th of October. Again, feels really resonant with the conversation we were just having. And then on the 5th of December, we're focusing on improving waiting list equitably and thinking deeper about the importance of a partnership approach in that. I'm going to leave it there. I'd like to thank you all for your participation, some great questions, some great kind of comments and resources and ideas shared in the chat, and to thank our panel. Thank you for bearing with us with a few technical issues. Mark and Jack and Kate, fabulous to have your insight into this. Thank you very much. We'll close it there.